Good afternoon, everyone. Thank you for joining us today for Understanding the COVID-19 Vaccine with Drs. Milton Gaviria, Kelsey Williams, and Amaya. We ask that you mute your mics and keep your cameras off for the duration of the program. Please use the chat function to submit your questions and comments, which will be addressed by our panelists at the conclusion of the program. As always, we ask that you take a few minutes to complete a short survey that will be shared to you via email. And without further delay, please help me in welcoming Dr. Milton Gaviria.
Thank you very much. It's a pleasure to be here today. First of all, I want to thank Miami Cancer Institute for giving us the opportunity to discuss this very important topic regarding understanding of COVID-19 vaccines. I also want to thank Dr. Kelsey Williams and Dr. Amaya for participating and collaborating with me to put together this presentation. So COVID-19 disease is an ongoing issue. I plan to cover different topics. We'll be covering the epidemic of COVID-19, the number of people affected by this. I'll give an introduction on the vaccines, the different types of vaccines. Then Dr. Williams will talk about the vaccines being used here in the United States. And later on, Dr. Amaya will touch on the vaccination programs for cancer patients. Next slide, please. So COVID-19, an ongoing critical pandemic, global pandemic, that has caused multiple social, emotional, and healthcare issues in the globe. This has affected us in many different ways. Here in the United States, as of yesterday, we had 27 million cases with approximately 465,000 deaths. Important things to say is that the United States leads the number of cases, followed by Brazil, United Kingdom, Russia, France, and Mexico. Something very important that just to put in perspective is that we are average approximately 160,000 cases in the United States every day. The mortality the last few days has been between 3,000 and 3,300 cases per day in the United States. Something important to say is that the COVID-19 became the leading cause of death in this country as of December 2020. And with the average of deaths, approximately 3,300 per day that we have had in the last few weeks, COVID-19 has surpassed the number of deaths caused by cancer and coronary artery disease together. That is approximately 3,000 daily. So certainly this disease has caused lots of death, economical stress, economical hardships, social distancing, and emotional distress on all of us. Next slide, please. These are the number of cases here in Florida, and you can find information at the dashboard for the Florida Health Department. Basically here in Florida, approximately 1,750,000 people have been diagnosed with COVID-19. We have 74,500 hospitalizations, and the number of deaths is approximately 27,800 as of yesterday. I guess the most important to stress with this slide is that this pandemic has affected the low-income groups and the minorities especially. So these groups, low-income and minorities, have been disproportionately affected with increased number of cases, increased number of hospitalizations, and unfortunately, a higher number of deaths. Next slide, please. This shows the vaccine distribution here in Florida. Basically, as expected, most of the vaccine has been provided for people older than 65. This has been the group that has been targeted. And we have other groups like healthcare workers and first responders. We have to do a better job reaching out to minorities American Indians, Black communities, to provide and distribute the vaccine to all groups in the state of Florida. Next slide, please. When we look at the risk factors, we have become familiar and we now understand more of this disease that has been going on now for 13 months. So there are some groups that are especially affected and that have more worse outcomes. We know that people with older age, especially older than 65, have the tendency to get more ill, to more often go to the intensive care unit, and they have higher mortality. Other groups, like people with bronchitis and emphysema, chronic kidney disease, diabetes, hypertension, cardiovascular disease, obesity, or people who go to surgery during the incubation period for this disease. When we are in the hospital, we know that people who come with a higher respiratory rate, 24 breaths per minute or higher heart rate, they have the tendency to have to be more ill as expected. Also, people who have very low oxygen, especially what we call 90%. When we measure with a pulse oximeter and the oxygen saturation is less than 90%, this is also a risk factor for more complications. This is one of the reasons why we usually advise patients when they are doing well to measure the oxygen at home and to come to the hospital, to the emergency room, if the oxygen saturation is below 94%. We are also familiar with some laboratory tests that let us know when patients are at higher risk of having complications, and we act accordingly when we see these abnormalities. Sometimes we know it's time to move the patient to the intensive care unit. Next slide, please. Just a brief information regarding the disease. The median time, the average time of incubation for this disease, for COVID-19, is approximately 5 days, although can be as short as 3 days or as long as 14 days. But most people incubate the virus within 5 days, getting infected and developing symptoms. The symptoms the first week are what we usually call viral syndrome, that is fever, body aches, maybe diarrhea, headache, fatigue. Most people do well this first week. Usually what we see is that people, the second week is when there is a pro-inflammatory state. The body tries to counteract the virus, but sometimes this immune response may be excessive. And this excessive inflammatory response sometimes is what leads or what drives the damage to the tissues like the lungs and the kidneys. So it's especially important to pay attention to the second week of illness. And often this is the period where people may develop shortness of breath, cough, high fevers. Other people, fortunately, most of them improve. What we know from this disease is that 80% of people who get infected, they do not need to come to the hospital. They have a very mild illness. Only about 20% of people with COVID-19 has to go to the hospital because of fevers, shortness of breath, or sometimes diarrhea and dehydration. Of those patients, about a quarter go to the intensive care unit. And unfortunately, we know the mortality is around 1 or 1.5% of the total. Next slide, please. This is a busy slide. Basically, with this, I just want to show when we look at the groups 30, 39 years of age or older, as people get older and they develop this disease, there is a tendency to have more complications and to have worse outcomes, higher mortality. We see that people, when they are between 50 and 64 years of age, the hospitalization is 4 times as high as people in their 30s or 20s. When they are in their 60s and 70s, maybe 5 or 8 times as high. And people who are older than 85 years of age, the hospitalization rate may be 13 times as high, and the mortality is certainly much higher. Next slide, please. So I want to introduce, since we are going to talk about vaccines, I want just briefly mention how the virus enters to the cells, and then how we are trying to develop an immunity to counteract the virus and to prevent disease. This virus has the spikes. The name is coronavirus because of these spikes. Give like a corona, create like a corona on the virus. The virus uses these spikes to enter the cells of the human body. Inside the cells, the virus opens up, and the genetic material goes into the machinery that we have in our cells to produce proteins. The virus is synthesized, and then the virus is basically, if you will, excreted from the cells and goes on to infect other cells and to elicit an inflammatory response. What we are trying to do with the vaccines is that we are trying to develop antibodies that block the S protein, those little spikes that you see on the outside of the virus. By blocking those spikes, we render the virus unable to enter the cells, the human cells. And in doing so, the virus cannot cause disease. So there are two important branches of the immune system: the antibodies that are very important to block the virus, and there are other cells that are the lymphocytes that can also help in the immune response by destroying cells that are infected with this virus. Next slide, please. So approximately 30 vaccines are being studied. There are certainly about 200 projects, but vaccines that are in clinical trials are approximately 30. And of those, only a few trials have ended, mostly the trials with the RNA vaccines. I want to briefly mention the different types of vaccines that are being developed. There are virus vaccines in which a whole virus is used. The virus can be inactivated. If you will, basically you could say that the virus is dead. We say inactivated. So the person gets exposed to the virus and to the genetic material and the proteins, but the virus doesn't do much. And we try to stimulate an immune response. The virus can be weakened, or what we call live attenuated. These type of vaccines sometimes are difficult to handle, in the sense that people who are immunocompromised cannot receive these vaccines. So far, there are no ongoing studies in this area. Now, we have the nucleic acid vaccines, DNA and RNA. The most important, the Pfizer vaccine and the Moderna vaccines that are being given at present are RNA vaccines. And I'll briefly touch in this. What we do is that the messenger RNA, that is basically what codifies for the genes of the S protein, the spikes that I showed previously, are packaged in a small lipid packets. These lipid packets allow the messenger RNA to go inside the cells. The messenger RNA quickly goes to the area in the cell where proteins are produced, and the S protein is produced, the S protein of the virus. But it's important to say, first of all, the messenger RNA doesn't go into the nucleus of the cell, so it doesn't affect our DNA. It doesn't touch our DNA, it doesn't go into the nucleus. And once the protein is produced, the messenger RNA is quickly degraded by our cellular enzymes. The S protein is produced, it is shown to the immune system, and the cells of the immune system quickly produce antibodies against the S protein. So as I mentioned earlier, these antibodies, what they do when we have the infection by the real virus, is that the antibodies coat the virus. In doing so, the virus cannot attach to the cells, especially in our respiratory tract, and therefore the virus cannot cause disease. I'm gonna pass now to Dr. Kelsey Williams, who is gonna talk specifically about the messenger RNA vaccine.
Thank you, Dr. Gaviria, for that introduction, and thank you all for joining. Over the past month, I received countless questions regarding the COVID-19 vaccine. So in preparing for this presentation, my colleague and I compiled those questions that we received most commonly. So let's jump right in. So as I'm sure you are all very well aware, as of mid-December, we have 2 vaccines that are being mass distributed around the world. These are the Pfizer and Moderna vaccines, and both of these display similar efficacy and safety profiles with trial results that are proving that the vaccination with one of these 2 vaccines has a 90 to 95% effectiveness at preventing severe COVID-19 and hospitalizations associated with COVID-19. All racial and ethnic groups and age groups, with the exception of those 0 to 15 years old, were included in these trials. Therefore, those that were included in the trials were well representative of the general public. There are no real safety concerns in these trials, as there were no cases of mortality, and there were 0 hospitalizations due to severe COVID in both groups. Overall, there was a very low rate of serious side effects, although there was one side effect that has been widely reported in the media, which is Bell's palsy, yet when reviewing the trial, this really should not be too big of a concern. To paint the picture for you, there were 3 cases out of 30,000 in the Moderna trial and 4 cases out of 43,000 in the Pfizer trial. But that's not a sufficiently large number of cases to conclude that this was beyond what would naturally be observed in the population of this size by chance. There are no cases of Guillain-Barré or transverse myelitis. Side effects associated with the vaccination are common, but these are mild for the most part and do wane after 48 hours. And we're going to chat more about side effects in the coming slides. A word that has been thrown around a lot is reactogenic. Just what does this mean? So what does it mean is that what happens is side effects in most people who receive them, this is just reflective of the immune response that they generate. So we put these vaccines in the same side effect category of the Shingrix vaccine. So we're going to touch now on how vaccines work and some of the concerns that have been raised regarding these products. So earlier, Dr. Gaviria gave a great introduction to what mRNA vaccines really are, and I want to take a minute to address some of the concerns that have been discussed in social media and in the news. A question that I get quite often is whether we should be concerned that these vaccines were potentially pushed out too quickly. It's important to note that although these are the first mRNA vaccines to be broadly tested and used in clinical practice, scientists have been working on mRNA vaccines for years. Yes, vaccine trials usually take years and years to get approval, although due to the severity of the situation and climbing case rates, the federal government supported these endeavors financially, and essentially all virology and vaccine experts put their day-to-day responsibilities on hold to work for the common goal. So therefore, all the wealth of knowledge coupled with financial support led to the vaccine being available quicker than ever before. Rumors regarding the vaccine affecting someone's DNA should be laid to rest. As Dr. Gaviria discussed, these vaccines, the mRNA carries instructions to make the SARS-CoV-2 spike protein. Those are the prickly projections on the surface of the virus. Once that vaccine is injected, the mRNA is taken up by your own body cells and instructs those cells to make the spike protein. The spike protein then induces an immune response and mimics the way we fight off infections that protects us from natural infection from SARS-CoV-2. Enzymes in your body degrade the mRNA, so again, no live virus is involved, no genetic material enters the nucleus of the cells. So now that we explained all of the ins and outs of the mRNA vaccines, you may be wondering, with these 2 vaccines that are widely available and several in the pipeline, how do you know which one to pick? So both the Moderna and Pfizer vaccines work the same way. They have similar safety, they have similar effectiveness, they both require 2 shots. Therefore, you should just get whichever one you're able to get. The only caveat to this is for our younger patients that fall in the age group of 16 to 18. So since Pfizer did not include patients younger than 18, the Moderna vaccine would be the only vaccine available for this age group. Studies in children are ongoing, although the population that is 21 years old and younger only make up 26% of the population diagnosed with COVID anyway, and the mortality rate in this group is 0.08%. Therefore, the risk of severe COVID in general is very low. Both trials excluded pregnant women, although pregnancy is not a contraindication to vaccination, and this decision should be discussed with your OBGYN. So again, no real differences seen between vaccines in regard to safety, efficacy, although there is a difference in the timing of the second shot. So when do I receive the second shot? Depending on the vaccine you receive, a 3 or 4 week window between dose 1 and 2 will be required. 21 for Pfizer, 28 days for Moderna. You may be wondering, why do we need 2 vaccines anyway? So essentially, the goal of the first vaccine is to prime your immune system, and then the second one boosts it. Although most participants in the trials receive their second dose on or close to the scheduled time, there really is no biological reason why receiving the second dose late would diminish the effectiveness of the vaccine. Just provided it's received before too long of an interval, in practice, the second dose should be given as soon as possible after the missed scheduled dose. Of note, on January 21st, the CDC updated its guidance on the interval between vaccine doses, providing additional information on delaying the dose. So originally it was get it on the 21st or 28th day, but now the CDC is saying that the second dose may be scheduled for administration up to 6 weeks or 42 days after the first dose. So although there are currently limited data on the efficacy of mRNA COVID-19 vaccines beyond the 21 to 28 day window, if the second dose is given later than this, the series does not need to be restarted. So what about mixing? Can I mix and match the vaccines? Can I get 1 Moderna and then 1 Pfizer? Well, I know I've been chatting about 10 minutes about how these vaccines are essentially the same thing, but with that being said, these vaccines are not interchangeable. Why? It's a very simple answer. The most popular answer in medicine, it just wasn't studied that way, so it can't be recommended. So although the mechanism of action of these 2 vaccines is the same, they're not identical, and the second shot should be the same one that you got for the first shot. Note that there is no data to indicate that receiving a different product for the second shot would be unsafe or less effective, but the vaccines have not been studied this way, and such hybrid dosing strategies should be avoided. Say for some reason you are unable to stick with the same product, or for whatever reason you can't find Pfizer and you originally got Pfizer and you get Moderna for your second shot, there's no need to panic. There's no, we want to avoid this, but if that happens, no need for panic, no need for additional doses of either vaccine. The CDC advises that in this situation, the person would be considered fully immunized. So moving on to the most popular question that we get, what side effects should I anticipate? The most common side effect is pain at the injection site, essentially in the 12 to 24 hours after administration. Around 1% of participants in the trials categorized this pain as severe. Fatigue and headache are also relatively common side effects. High fevers are not very common. In general, side effects are more common in younger vaccine recipients than in older patients. The second shot also induces more side effects than the first. You may want to refrain from these side effects by taking Tylenol, but we recommend not taking Tylenol. Do not take Advil. Do not pre-medicate before you get the vaccine. There's a theoretical risk that this could blunt your immune system and make the vaccines less effective. Again, this is just a theoretical risk. There's no real data that supports this, but right now that is a recommendation. With that being said, if you do get side effects, you are able to take Tylenol or Advil after you get the vaccine. So I'm going to move on now to serious side effects that you may hear about, again, in the social media, nightly news. But before we do so, I just want to acknowledge that the safety of COVID-19 vaccines is going to be in the spotlight for some time. These are new vaccines, this is a new disease, rare events will appear in the news, and this amplifies attention and worry, and it makes it seem like these side effects are a bigger risk than they actually are. So I hope to put these uncommon events into perspective, and I think it's important to hold on to the important fact that these risks are far lower than the risk of actually getting sick with COVID. So we'll move on now to serious side effects and how concerned should you really be. To keep it brief, cases of serious side effects like anaphylaxis are very, very low, and generally these occur within the first 30 minutes following vaccination. The current leading suspect in causing these reactions is polyethylene glycol, or the lipid nanoparticle that surrounds the mRNA. Both compounds are present in both vaccines. So it's important to emphasize that these allergic reactions are really uncommon. The current estimate is that anaphylaxis will occur with the Pfizer vaccine at a rate of 6 cases per 1 million doses, and the Moderna vaccine 2 per 1 million. So to put this into context, the rate reported with penicillin, an antibiotic that I'm sure most of our listeners have had, anaphylaxis with penicillin is 1 in 5,000. So substantially lower risk of anaphylaxis with this vaccine versus a very common antibiotic that's been around forever. Again, I'm not trying to take anaphylaxis should be taken lightly. Therefore, if you do have a history of serious allergic reactions or you have a history of reactions to other vaccines, you are at a higher risk. So when you go for your vaccine, you should tell your vaccinator of your history and be closely monitored for 30 minutes following the vaccine. Everybody else, usually you're only monitored for 15 minutes. So this patient population should be monitored for 30 minutes. All right, so you have your vaccine, and now you want to know if you can show off your beautiful face again, or if the masks are here to stay. So many commentaries on the results of the vaccine trials cite a lack of information on asymptomatic infection. This is a limitation in our knowledge about the vaccine's effectiveness. Indeed, this is a theoretical concern. I mean, up to 40% of patients who get infected with SARS-CoV-2 have no symptoms, but they can still transmit the virus to others. So until we know whether the vaccines protect against asymptomatic infection, we should continue masking until we know more about this topic and more about the studies that are to come. Although that is my politically correct answer, I do want to shed some positivity on this. There are several good reasons to be optimistic about the vaccine's effect on disease transmission. First, in the Moderna trial, participants underwent nasopharyngeal swabs at baseline and then again at week 4 when they returned for the second dose. And so those at baseline that didn't have any symptoms, 39 patients in the placebo group versus 15 in the mRNA vaccine group had positive SARS-CoV-2 by PCR at week 4, meaning there was 2/3 less with those that got the vaccine. So this data suggests that even after 1 dose, the vaccine has a protective effect in preventing asymptomatic infection. Another point is findings from population-based studies now suggest that people without symptoms are less likely to transmit the virus. The thought is that if you don't have any symptoms, you likely have a lower viral load, less likely to pass it on to others. And then another reason, many of the vaccines in wide use for years and years protect against both disease and transmission. So it would be very unlikely that this wouldn't have any effect on transmission. Again, the protective effect of any vaccine, including this one, is never going to be 100%, but expert opinion has weighed in on this topic, and the overall consensus is that the likelihood that these vaccines will reduce the capacity to transmit virus remains excellent. So for those of you who have had COVID or someone in your family has had COVID, do they need to be vaccinated? The short answer is yes, yes. Everybody should be getting a vaccine. Some of the people who participated in the clinical trials had evidence of prior SARS-CoV-2 infection, and the vaccines were safe and effective in this group. Because reinfection after recovery from COVID-19 is rare in the first 90 days, it's completely reasonable to defer immunization for the first 90 days. However, if someone wants to be immunized sooner, there's no contraindication. The only ask is to at least wait 14 days, and this is just due to the risk of transmission. The last point I wanted to share on this that I find really interesting is that vaccine-mediated immunity was more robust than natural immunity in these trials. So in other words, the patients that your immunity was stronger after a vaccine than your immunity after having COVID. So we can surmise that this vaccine-mediated immunity may be more effective against the variants, it may be longer lasting, and more effective than the immunity received by a COVID infection. Due to time, I can't cover all the particular patient-specific scenarios that you may fit in, but some of the most common questions I receive are addressed here. So first up, if you previously had COVID and you were treated with a monoclonal antibody, such as bamlanivimab or convalescent plasma, you should be waiting at least 90 days to get the vaccine. These treatments, like bamlanivimab, might inactivate the vaccine, making them less effective. Therefore, give your body 90 days before signing up for vaccination. Second, I would hate to see this, but it definitely could happen. Say you are infected with SARS-CoV-2 between vaccine doses 1 and 2. You'll likely have a mild reaction given that you have some immunity, but it is recommended to defer shot 2 until you have fully recovered and you're asymptomatic and it's been at least 14 days since diagnosis. No need to worry if your second vaccine isn't given like on exactly 21 days or 28 days. As I previously mentioned, the CDC has extended that interval to 6 weeks. Finally, for our expecting mothers, vaccination is truly up to you. Since these vaccines do not contain live virus, there's no expected risk to the fetus if COVID-19 vaccine is received. Additionally, there may even be benefits to getting vaccinated while pregnant because the mother could provide immunity to her baby via passage to the placenta. Any pregnant patients should discuss the risk versus benefits with their OBGYN. It's been a pleasure sharing this info with you. I'm now going to pass the torch to my colleague, Dr. Amaya. He's an infectious diseases and bone marrow transplant pharmacy specialist at Miami Cancer Institute. So he will go over what you need to know regarding COVID-19 vaccination for people with cancer.
Thank you for that introduction, Dr. Williams. Hi, everybody. Good to be here. Thank you for having me on the call today. So I'm going to be covering whether or not patients should be vaccinated with COVID-19 if they have cancer. And the short answer to this is yes, we believe that cancer patients should receive the COVID-19 vaccine. And to be upfront, not any immunocompromised patients were included in any of the studies so far. So we don't have a lot of efficacy or safety data to go off of. However, there are several large organizations throughout the world that I have listed on the screen right here: the American Cancer Society, the European Society of Medical Oncology, the National Comprehensive Cancer Institute, American Society of Transplantation and Cellular Therapy, and the list goes on. All of these organizations do follow the CDC recommendations that patients with cancer may be offered vaccination against COVID-19 as long as the components of that vaccine are not contraindicated. So we can go to the next slide. So the reason why they believe people with cancer should receive the COVID-19 vaccine, even though we don't have a lot of safety and efficacy data with it, is that we know that patients with active cancer have increased risk of complications from this disease. And this is seen more specifically in our hematologic malignancy patients. So those are patients with blood cancers, as well as patients with lung cancer. Additionally, patients who have tumors with solid tumors within the first year of diagnosis and are undergoing active chemotherapy. Next, the immunization can protect patients from contracting the infection and prevent or lessen the effects of severe infection. So as we know, even if you get infected with the COVID-19, it can be mild, moderate, or severe. And a lot of our patients that have cancer actually can develop more severe infection. They're at a higher risk for that. We've seen that in many, many studies. And that's why we do believe it is important to vaccinate our cancer patients. So we can go to the next slide. Another question that comes up very frequently is if the vaccine is safe in patients with cancer. And although we don't have any clinical data to support this, because no patients were enrolled, there are previous studies that we can look at, such as the influenza vaccine. That has been studied in our cancer patients pretty readily, and it is very similar. And when I say similar, going back to what Dr. Gaviria had spoken about in his part of the lecture, it is inactivated. It's not a live virus vaccine. So because it is not live and it's inactivated, we believe it to be fairly safe. And there's really no major side effects or unique side effects that have been reported in any of the immunocompromised patients in regards to some of our other vaccinations that we provide for our cancer patients. So we can go to the next slide. Now, is it effective in patients with cancer? So this is a big question mark still. And it's going to depend on what type of cancer you have It's going to depend on what type of chemotherapy that you're undergoing currently. But we do believe, based on other studies and other, influenza vaccine, that the effectiveness of the COVID-19 vaccine can be similar to patients without cancer. However, it does change, like I said, in patients who are either, a hematopoietic stem cell transplant patient, so a bone marrow transplant patient, patients who are currently receiving immunosuppression. So a lot of our patients sometimes are going to be on corticosteroids for a long period of time, or some other type of medication that is going to suppress their immune system, including chemotherapy. So those patients might have less response to the vaccine. In addition, any patients receiving a B-cell depleting agent. So a more common one here is rituximab. Patients who are receiving that can also be at a reduced effectiveness of the vaccine. And additionally, chimeric antigen receptor T cells. So that is a way that we can attack some patients with cancer. And in those patients, similar to like our stem cell transplant patients, have probably a decreased effectiveness. So it's really going to depend on what type of cancer you have, what type of treatment you're undergoing. So I encourage any patients out there right now who have cancer who are listening to this to discuss this with their oncologists for more information regarding their own treatment. So we can go to the next slide. There are some preliminary recommendations that the NCCN has come out with in the previous month about vaccination in our cancer patients. So this is one of the biggest organizations for cancer, and their recommendations are based on expert opinion. And that is because we don't have a lot of, the immunocompromised patient population was not studied very well. So this is based on a lot of our expert opinion and advice from the committee. And they recommend that cancer patients with active cancer or receiving active therapy should be prioritized for vaccination and should be immunized when vaccination is available to them. They also recommend that caregivers and household close contacts should be immunized when possible. And this is because patients who, this is a very transmittable disease. So if you're around a caregiver who is at risk to contract COVID-19, they're also at risk to transmit it to you as a patient. So in order to mitigate that risk, it would be important to also have anybody who is near the patient who has cancer to be vaccinated as well. We can go to the next slide. Now, this slide is the recommendations from the NCCN guidelines that they came out with. And to orient you to the table, on the left-hand side, we have the type of treatment and cancer type. And on the right-hand side, we have the timing in which they recommend the vaccination be given in accordance to what treatment the patient is currently undergoing. So on the first bit here, we have our stem cell transplant patients. So whether that is an allogeneic, autologous, or even patients receiving cellular therapy such as CAR-T that we mentioned before, they do recommend that there be at least a 3-month grace period after receiving a transplant or CAR-T cell therapy. This can range from 3 to 6 to 9 months. It's really going to depend on the patients and what they're currently medications on. A lot of our patients will be on immunosuppressive therapy more than the 3-month mark. And if they are on immunosuppressive therapy, then the vaccination really probably won't work. That's because it's not your body's not going to amount that same immune response that a healthy patient would. So we do recommend holding off, and that's going to be a conversation to have with your oncology physician or pharmacist. Then, can we go back? The next set that we have on this slide is the hematologic malignancies. So these are patients with blood cancers. And as you can see here, there's 3 different boxes that the NCCN lists. It is the intensive cytotoxic chemotherapy, marrow failure from disease and or therapy expected to have limited or no recovery, and long-term maintenance therapy. So in general, I think the consensus is that we would love to have all of our cancer patients vaccinated if they are not contraindicated to receive the vaccine. However, there are certain instances like on this slide that patients won't have the immune response that would be effective in giving them. And in addition to the stem cell transplant, the hematologic malignancies undergoing active cytotoxic chemotherapy, your blood counts will drop whenever you are on those cancer regimens, such as your absolute neutrophil count. And in this case, patients who we do recommend it just giving the vaccine when available, but it's really going to depend on what type of cancer where you are in your regimen, if it's a new or if it's, you're on maintenance therapy. Because if it's most cancers, you're going to want to treat pretty readily, especially if it's an aggressive cancer, immediately. So there is recommendations that, you have to talk to your oncologist about this, but for the most part, delaying vaccination might be important because it's probably better for you to receive your chemotherapy regimen rather than the vaccine at that point in time. So now we can move on to the next slide. So just to summarize what we've talked about today for our vaccines in patients with cancer, the patients are at an increased risk for complications from COVID-19. So it is important to weigh the risks and the benefits of the vaccine with your oncologist. It is recommended by a bunch of organizations, as I stated before, that the benefits of the vaccination do seem to significantly and substantially outweigh the risk, though. But it's always a risk benefit, especially with our cancer patients and the chemotherapy regimens that they undergo. Those don't come without their complications either. So this is a conversation between the provider and the patients. Lastly, on this slide, the timing depends on the individual therapy, as I said, whenever possible, but the administration of the vaccine should be performed before initiation of chemotherapy. So at least 2 weeks before, if you can, most chemotherapy regimens, because the vaccine needs to have at least 2 weeks to actually build the antibodies in your for your immune system actually take effect. So we do recommend it in most cases at least 2 weeks prior to starting chemotherapy, if that is the decision to proceed with it. We go to the next slide. Now, I did want to touch a little bit on the variants of COVID-19. So the SARS-CoV-2 virus that has been going around in the news, talking about the different strains that have appeared in the United Kingdom and South Africa, Brazil, and other parts of the world. So just a little bit of background is that SARS-CoV-2 is a virus, and viruses constantly change through mutation. This is nothing new. We know this from our flu. So influenza mutates just like the SARS-CoV-2 virus does, and we have to get vaccinated every year for that type of vaccine because of the fact that there's new strains coming along. So this is expected to happen, and it will occur over time. I will say that the SARS-CoV-2 virus does not replicate or mutate as fast as the influenza virus, but because it is so infectious and it's going into different hosts, different people constantly at a much higher rate than influenza, we are seeing that it is mutating probably a little bit faster than we would normally expect it to mutate. Multiple variants have been seen, and some variants actually seem to spread more easily and quicker than other variants. So the original SARS-CoV-2 that appeared in Wuhan, China about a year ago now, that one in comparison to some of the ones that have appeared now, the one that appeared in South America or South Africa, as well as the United Kingdom, those two actually appear to spread more easily and transmit a little bit more easily. So we can go to the next slide now. This slide is comparing the three most common ones that you will hear in the news. So I'll orient you to this graph. On the left-hand side, I have the variants on the top. The B117 is considered to be the United Kingdom one, and it has 23 mutations. In comparison to the B1315, South Africa, and then the P1, which is the Brazil one, those have less mutations than actually the United Kingdom one. However, the main thing I would like to point out is the number of key receptor binding domain mutations. So what the key receptor binding domain is that's the business end of the SARS-CoV-2 virus. So you can think of it as like, if there's any mutations that happens at that site, that's where the antibody is actually going to bind to neutralize the virus. So if you have mutations there, you're not going to be able to bind as well as you normally would. So the more mutations, the worse off it's going to be able to bind. And as far as the United Kingdom one, it only has one mutation that we are aware of in that region. So in most of the studies that we're going to look at, they do see maybe a little bit of decreased efficacy or effectiveness, but not that much, only because there's only that one strain or the one mutation. However, in the South Africa and the Brazil strains, those do have a couple more mutations in comparison to the United Kingdom ones. So there is some concern there that there will be some resistance to the vaccines that we currently have. However, there are some trials that still state that it's protecting you against severe COVID-19. So it might not be mild or moderate, but for severe requiring hospitalization, the studies that we do have so far do say that it will protect you. So that's a good thing. It's a reason for optimism. We don't really know if there's any change or increase in the death toll that it might have. So that hasn't been established yet in several, these three strains really. And lastly on this slide, I've already talked about the resistance part there and the effectiveness, but lastly is, where is this right now in the United States? So the United Kingdom variant has been reported per the CDC in 33 states, the South Africa variant in 3 states, and the Brazil variant in 2 states. We can go to the next slide. And specifically, this is a map taken from the CDC website. Looking specifically, I want to look at Florida because that's where we are currently. Right now, the only strain that has appeared here is the United Kingdom so far that we know. So the South Africa as well as the Brazil, as of 2 days ago, have not appeared in Florida. However, I will say that the United States and even some other countries, we're not always doing tests for looking specifically at different strains. Generally, if you go get your nasal swab done and get tested for COVID, it'll come back positive or negative, but it won't tell you what the strain is. So for a large portion, a large time period prior to the previous month or so, we haven't really been checking to see what the strains are. So this might be underreported. I imagine that there's probably, it's probably more than what's posted on the CDC website, but this is what they have as of right now. So we can go to the next slide. So to summarize kind of the effectiveness of the 2 vaccines that we currently have, the evidence that we have so far suggests that the vaccines appear to remain effective against the United Kingdom variants, but maybe they might have some decreased effectiveness against the 2 other strains. However, it does appear that these vaccines will work against severe disease and hospitalization. However, we still have, these studies keep coming out daily, new evidence comes out daily, things always change, it's hard to keep up to date. So I will put a disclaimer that, this is still yet to be fully elucidated, but this is currently the landscape and what we feel is going to be, what is happening currently. We can go to the next slide. We wanted to end today's webinar just giving everybody information as to how to schedule a COVID-19 vaccine in Florida. And the Florida Health Department, as well as the State Emergency Response Team, does have instructions on their websites. This is readily available. So you can visit floridahealthcovid19.gov, and that'll give you the most up-to-date information in regards to the vaccination locations and whether or not you are eligible to receive your COVID-19 vaccine. If we can go to the next slide. This is taken off of the Florida Health Department website. They do stress that currently there is a shortage of vaccination. As you know, there's only the Moderna and the Pfizer currently that we have in the United States. That they're not FDA approved yet. So they just have an emergency use authorization. And there are way more people needing the vaccine than, so that the supply is much less than the demand. There's a very high demand for these vaccines. So we're working, and Miami Cancer Institute is doing their best to work with the state of Florida to vaccinate as many patients as we can in regards to how much we can get from the state. And the state does recommend that patients, just like Dr. Gaviria mentioned earlier in the webinar, who are at high risk be prioritized. So those at 65 years or older, healthcare personnel, residents and staff of long-term care facilities, and persons deemed to be at higher risk. So maybe even some of your cancer patients, depending on your conversations with your oncologist. So this is here for your reference. We can go to the next slide. There are also several resources we'd like to share with you all here on this slide. And that will conclude today's webinar. We are happy to take any questions that might have appeared in the chat box, but we do want to thank everybody for listening in today. And we appreciate all of your time.
Thank you, Lee, and thank you, Dr. Gaviria and Kelsey, for presenting today. I am going to ask that participants of the audience maintain their mics muted and their cameras off. And if they do have questions, to please use the chat. Throughout the presentation, we did receive several really wonderful questions, so I will start addressing those, and the speakers can decide who would like to respond. So one of the first questions that came in is, when is herd immunity expected to be achieved?
I can take that. Well, usually what we know is that we need approximately 70 to 80% of people in the community immune. Studies that have been done so far show that only as little as 10, maybe 20% of the population, depending on different areas, are immunized at this time. So we have a long ways to go before we can reach that level of immunity that is, as I said before, 70 to 80%. One caveat that we have now is that we have the variants. We still don't know how immunity is going to play out with the new variants. There may be some cross protection for some of them, but we don't know fully. This is all a work in progress. So at this time, the best option that we have to be immune and to be protected is to get the vaccine. Any other comments from Dr. Williams or Dr. Amaya?
The only thing that I was going to add is, yes, we need 70% of the population, and we only have about 10% that are vaccinated, but you should also consider the millions of people that have had COVID. So like experts say that we're probably way underestimating the amount of people that have had COVID. So it may be faster than we think, just because not everyone, a lot of people, 40% are asymptomatic, so very unlikely that people were infected and just didn't know. So that entire cohort of people would be included in the number needed to reach herd immunity.
Thank you, Dr. Williams. Another question that came through is more testing needed to help have more data on variants?
Yeah, I mean, certainly we have to do different type of studies. One study is to look at the molecular aspects of the virus, circulating in the community, to really know if that virus is mutating or not. And then the other studies are epidemiologic studies, or studies in the population, to see how that new virus is affecting people, is affecting us. For instance, in the United Kingdom, they discovered these variants because back in September, they noticed that the mortality and the number of cases were decreasing in most of the country, but there was a region where the cases were and the hospitalizations were actually going up. So they said, what is going on there? They started looking and they analyzed the virus in that population, and they found the variant. So we have to do studies at different levels, at molecular levels, and also at epidemiologic or population level, to see how those variants affect us. All this is a work in progress, and there will be much more information coming up. I wouldn't be surprised if maybe in a few months we have a second webinar like this, just giving an update.
Thank you, Dr. Gaviria. Another question that came in says, my understanding is that the Pfizer and Moderna do not know if their respective vaccine transmits the virus, mostly because they did not actively observe this phenomenon in their trials. They were focused on prevention of illness and death. Will Pfizer and Moderna be doing follow-up studies to see if their vaccines do indeed prevent viral transmission?
That's a great question, so I can take that one. So as I talked about, Moderna did look at the rate of viral transmission between doses 1 and 2, and they did find that there was a 2/3 reduction in transmission of those that were vaccinated versus the control group. But I wish I knew if there was ongoing studies. Pfizer, Moderna, as far as I'm concerned, please correct me if I'm wrong, or Dr. Gaviria, but I do not believe that I have heard of any ongoing studies really specifically for Moderna and Pfizer. I know AstraZeneca looked at this, but I do not believe that I've heard of any other follow-up studies looking at that in particular.
I agree. Yeah.
Okay, is there any difference between dose 1 and dose 2? For example, is the Moderna first dose a lesser strength than the second dose?
So there's no differences in the doses. It's the same it's like the same milliliters, the same strength from the first dose to the second dose. It's I think it's a misconception that the first dose is, since there's more like side effects with the second dose, a lot of patients feel that maybe the second dose is like a larger concentration or they're like higher strength, but it's not. They're exactly the same.
Thank you. Another question that came in is regarding pregnancy. What about women that are trying to conceive or are currently pregnant? Can the vaccine affect fertility or the pregnancy?
So that's a great question. I looked into this quite a bit, and I know that there was like rumors when the vaccines first came out that there was concerns about this, and those have been laid to rest. I believe there was, I don't know if it was 26 or 28 patients, but one of those numbers of women were got pregnant after they got the vaccine. They didn't in particular like look at this, but 28 women were pregnant after getting vaccinated. So there is no concerns. As I mentioned, it's not a live virus. And the concern with vaccination in pregnancy is always with live viruses. It's not with mRNA vaccines. So no concern with fertility.
I agree. Yeah.
Thank you. It says here, only patients on B-cell monoclonal antibody is exempt, or are all other immunotherapies can get the vaccine?
Hi, I can take that. Good question. So it's not that patients who are receiving B-cell antibody therapy can't receive the vaccine. It's just that we kind of have to wait. And that's just because of the inherent nature of how the vaccine works, as Dr. Gaviria had mentioned previously. So this is like B-cell mediated antibody response, right? So if you no longer have those B cells to create those antibodies, then giving you the vaccine really won't work. In regards to other immunotherapy, it might be a little bit different, the timing. It's going to depend individually on the regimen that you're receiving, and a discussion kind of with your oncologist though, because the timing is really not well defined.
And to follow on that question, it says here, what about other transplant patients on immunosuppressants?
Yes, so some of our bone marrow transplant patients, specifically more of our allogeneic transplant patients, so those receiving stem cells from another person, not their own cells, those patients tend to be on immunosuppressive therapy, for months after their transplants. And while you are currently undergoing treatment with immunosuppression, it is also recommended that you don't receive the vaccine at that time, because we're actively suppressing your immune system. So giving you the vaccine, your body won't actually be able to mount that immune response that we would like it to. So that's another reason why it might be more than just 3 months. It might be 6 months, it might be 9 months. There are also other markers that we look at, such as your CD4 count, but I'd encourage you to speak to your oncologist about that.
Thank you. Thank you, Lee. And here I have a question. How is the COVID vaccine similar to the flu vaccine? Will we be getting it every year?
I can take that one. Well, they are totally different vaccines at the molecular level. As you have probably heard, the Pfizer and the Moderna vaccines are messenger RNA vaccines. This is the first time that this type of vaccines are being used. As Dr. Williams mentioned earlier, the platform and the studies were ongoing for several years, but specifically used in humans and human trials. This is the very first time. So in that sense, influenza vaccines are totally different. They are either inactivated or live attenuated virus vaccines. Regarding the timing, my personal bias, I believe that most likely we'll get to that point, to the point that, especially if we start seeing variants and mutations of this virus, like most likely will happen, we may get to the point that every year we may need to be vaccinated. At present, what happens is that regarding the flu, there is surveillance around the globe. and the strains that are more prevalent are put into the vaccine, usually 3 or 4 strains. Something similar might happen for coronavirus. There may be surveillance around the globe, and based on the most prevalent strains or variants, then we may have to get a yearly vaccine.
Thank you, Dr. Gaviria. When is it projected for healthy individuals under 65 years of age to be eligible for the vaccine? Are they going to roll out based on age mainly?
So I can take that one. Right now, it's not really clear as to what the next steps are going to be. We do have, allocation issues, and we're trying to vaccinate as many people as we can. We'll continue to work with the states. Miami Cancer will continue to work with the state and in regards to, who the plan is for 1A, 1B, 2, etc. So we'll continue to monitor the situation, but at this time, it's hard to say exactly when that's going to take place.
Thank you. And what is the cost of the vaccine if a person does not have health insurance coverage?
So as far as I understand it right now, since this is being allocated, all of the doses were purchased by the government. I don't foresee anybody having to pay for the vaccine currently, but I don't want to be quoted. If my panelists have other thoughts on this, please speak up.
That's what I believe too. We haven't been charging anyone for the vaccine. We haven't even been asking for their insurance information. So at this time, I believe that there is no charge, and I haven't heard of any changes regarding costs or charging patients for getting the vaccine.
Another question, if I am going to be started on TALTs for an autoimmune condition, how long do I need to wait to get the vaccine? Should I get the vaccine before starting treatment?
Hi, so I would direct that question to your healthcare provider, because as of right now, it is unclear as to when a patient should receive it. So I think that's a discussion best had with the provider.
Okay,
and I do want to add that usually, like if a patient is getting started, like if it's prior transplant or prior to immunosuppression, in other cases, not with specifically the COVID-19 vaccine, but with vaccination in general, they usually recommend getting vaccines before you undergo any of that. So this may be the same, but I agree with Dr. Amaya as far as discussing with your physician.
Thank you. And this is probably for the team. What action is Baptist taking to bring the vaccine to minority communities?
So to be completely honest with you, right now we are just trying to get vaccines. So at this time, I haven't heard of any what we're doing as far as like going out into the community. I know that right now we're just focused on getting enough vaccine to be able to start. My colleagues have anything additional?
Okay.
Yes, at this time, I think it's based on, state allocation, and, we're working with the states to ensure that we're vaccinating as many patients as we can. And they're working closely with, not only us, but also CVS, Publix, and a lot of our community pharmacy sites, where they're actively trying to get more vaccines out, more than just, hospital patients, and more so into the community. So.
Okay, another question came through regarding the death of a Mount Sinai physician 3 days after taking the Pfizer vaccine due to severe thrombocytopenia, a condition that decreases the body's ability to clot blood and stop internal bleeding. Does anyone with a bleeding disorder or on blood thinners need to be worried?
I can take that one. I am not aware of any guideline giving that recommendation. The specific circumstances of that case are being studied by the different groups and societies, the CDC and the Hematologic Society. But no, I am not aware that people with hematologic conditions need to take any special precaution. Dr. Williams or Dr. Amaya, any idea regarding?
I agree. I haven't heard of, I know that those patient populations are not excluded from getting the vaccine. I have read about that story, and I do think that this is like one of the instances that I brought up where, you know, with everything in the news, you always hear a lot about the bad, but nothing about the good. So I think it's important to realize that this was a one isolated case, and they don't even, they haven't even found out whether or not it was directly from the vaccine or if this patient had an underlying condition, and this was just just because of the timing that it was correlated with the vaccine when it really wasn't due to getting the vaccine.
I agree.
They're asking, why are the side effects of the second dose greater than the first?
I can take that. So basically, we know the first dose is what we call prime, and the second dose is the booster. So basically, as the name says, with the first one, the immune system just gets exposed to this protein, the spike protein, that is the one that our body is developing antibodies to. And then when we have the idea of the booster dose 3 or 4 weeks later, depending on the type of the vaccine, is basically to consolidate the immunization, because immunity may last just a couple of months if you receive only one dose. So the second dose basically consolidates the immunity and make it long-lasting. Certainly the body is gonna react in a stronger way because the body has already seen 3 or 4 weeks prior this protein. So it's basically the way that the body reacts. And in fact, most of the symptoms are just the pro-inflammatory substances that we have in our body reacting. So most of the fever or chills or body aches or headache or fatigue that we may experience, or sometimes diarrhea. Some people have mentioned to me, some patients, that they got diarrhea. Usually this lasts 24 or 48 hours, but most of these are the pro-inflammatory factors or mediators that we have in our body reacting to the vaccine. So if you will, it's just the way that our body reacts. Basically, that's what we see.
Just to comment on what Dr. Gaviria said, so patients, something that's really interesting is patients that have already had COVID that get vaccinated, they actually have serious side effects, or not serious, but they actually have the more pronounced side effects with the first dose. And that also provides evidence to Dr. Gaviria's theory about, with those patients, COVID disease is what primed their immune system, and then the second, like the first dose of the vaccine is what boosted it. So just something interesting.
Is there a surveillance system in place to keep and track side effects of those vaccinated?
Well, can take it. Definitely, there are always post-marketing surveillance, usually for 2 or 3 years. So after medications or vaccines are approved, or like in this case, are used as an emergency use authorization, there is always surveillance that usually goes on for 2 or 3 years, depending on the situation, maybe even longer. So those studies are ongoing. Any other comments?
When you get the vaccine, the CDC was recommending or asking patients that get the vaccine to sign up for this program called Be Safe, and it's basically an app that you go on and you say any symptoms that you're having, if you have any serious side effects, to report those. And not that I don't know this, but I'm sure that they're going to be using that to evaluate how patients react to the vaccine. And there's also, with all vaccines, there's a program called VAERS, and that looks at whenever someone has a serious reaction to a vaccine, the healthcare provider goes on there and fills it out, and then that goes to the FDA.
Thank you, Dr. Williams. Another question that came through regarding the vaccines that were planned for community, where individuals had the opportunity to register, but then they were unfortunately canceled due to just a reduced amount of vaccines being available. Is there an anticipated date when these individuals can re-register to receive the vaccine?
Hi, that's a great question. You know, I wish I could give you a better answer, but we really don't know at this time. This is such a fluid situation, and things constantly change on a daily basis that it's really hard for me to, you know, give you a pinpoint date as to when we expect that to happen. We are working closely with the state, as I said before, but we are working really hard at MCI to try to vaccinate as many of our cancer patients as we can. Not only cancer patients, but also our higher risk patients who are elderly as well. So I wish I had a better answer, but that's all I can say for right now.
Well, I think that concludes an exceptional presentation. We have not received any other questions in the chat. I don't know if any other participants that are hanging on tight are still interested in submitting a question, but otherwise I want to thank Drs. Gaviria, Dr. Amaya, and Dr. Williams for an exceptional presentation, very informative and very well crafted. I think the audience really enjoyed learning about the vaccine, and I think that the questions that we had were extremely engaging, and definitely we appreciate all the commentary. And if there are questions that come up after the fact, we will be sending a survey following today's presentation. And you can take that opportunity to send back any questions, but we'll be happy to share them with the physicians and our pharmacists, and they can let us know the response. So thank you again to our speakers, and thank you community for participating today. We look forward to, you know, continuing these discussions as the COVID virus continues to evolve. Thank you all.
Thank you very much.
Thank you for having us.
Thank you, everybody.